Hi everyone, and welcome back to the Endo Insight. In episode 1, we explored what endometriosis is, how it's diagnosed, and the everyday impact it has on those living with it. Today, we're building on that foundation. We're going to focus on fertility, IVF, holistic approaches, nutrition, and some of the biggest misconceptions surrounding endometriosis. Joining me is Miss Elizabeth Ball, a consultant obstetrician and gynaecologist. She is the endometriosis and chronic pelvic pain lead at the Royal London Hospital. Lisa, thank you so much for being here.
It's a pleasure.
Okay, so to start, can you share how you got into this field?
Well, I was working as a junior doctor, nowadays resident doctors, very early in my training, and I was actually assisting a senior consultant, and was doing a fairly straightforward procedure of clipping fallopian tubes for sterilization, and he just saw that my left hand and my right hand are of similar strength and precision, and then he said, "Look, you need to go into keyhole surgery. That you're suited for that." I followed that. Decades later, we got in touch again, and he was really pleased that he had signposted my career. So that's the story how I got into this laparoscopy and keyhole surgery. With regards to pelvic pain and endometriosis, again, I had really important mentors. One of them, an outstanding female surgeon in America, Grace Janik. There was also Charles Coe. These were really, the icons of my surgical life. I got the opportunity to work in the US and spend 2 years learning techniques to treat advanced endometriosis. The training happened in conjunction where the surgery and the fertility were linked together under the same unit. So we often looked after women who had fertility concerns and needed major endometriosis surgery. So that is where I learned this technique of fertility-sparing endometriosis surgery.
That's such a great story. It must have been so nice to hear how your senior saw real potential to encourage you down this path.
Yes.
Okay, so the first topic I do want to talk about is IVF. Before we dive into your expertise, let me set the stage for our listeners. IVF, or in vitro fertilization, is a fertility treatment where eggs are retrieved, fertilized in a lab, and then transferred to the uterus. It is important to emphasize that having endometriosis does not equal infertility. But for some endometriosis patients, fertility can be a major concern due to inflammation, scar tissue, or ovarian damage. Many wonder if IVF is a viable option for them. Lisa, when do you typically recommend IVF as an option?
Yes, as a clinician, I often think in flowcharts. And when I have a woman in front of me who has very severe advanced endometriosis and there's also pain involved, then I enter her for something called a multidisciplinary team conference where radiologist, fertility specialist, a general surgeon and myself sit together to plan the best way forward. If there is less advanced endometriosis or surface endometriosis, then we don't need that, large group for treatment. Often women fall pregnant spontaneously without even, needing fertility input when there's surface endometriosis. So this is sort of my way of going about it. I think there's a rule of thumb. So the message that I pass on to my clients is to, when diagnosed with endometriosis, it's a good thing to take a helicopter view and map out where in life you wish to have a baby, how many children you might want to have, and then we can talk about strategies, how all of this can be achieved when there are fertility wishes.
I've seen mixed views on whether surgery to remove endometriosis should happen before IVF. Some say it improves success rates, while others worry about the negative impact on the ovarian reserve. Is this true? And what is your general approach? Because, of course, every patient is different and it is case by case.
Exactly. So this case-by-case discussion usually happens in these multidisciplinary team meetings. As a rule of thumb, if there's fertility wishes, we tend to recommend in cases of severe endometriosis and infertility to do the fertility treatment first.
Okay.
And this is followed by surgery. A simple reason, especially if there's ovarian endometriosis, handling the ovaries and doing surgery on the ovaries hurts some of the eggs on the ovaries and reduces the ovarian reserves. So that's why IVF is often done first. In some cases, the embryos created during IVF are then frozen, not returned to the womb, and then we do surgery in the meantime, clear out all the endometriosis, and then the embryos are pulled back. Now, there are a few cases where this progression has to be done in a different way. There are some cases where IVF cannot safely be done without doing surgery first. There are cases, for instance, where the ovaries are not accessible because endometriosis likes to stick organs together and also pull organs out of place.
Yeah.
So if you visualize for it as part of the IVF, the eggs are harvested from the ovaries through an ultrasound-guided procedure through the vagina. So if the ovaries are pulled far away from the vagina, those would be women who ought to have their surgery first before they undergo IVF.
That's really helpful for patients that are weighing their options. Now, for those who aren't ready to start a family but are worried about their future fertility, let's talk about preservation. Fertility preservation is a big topic, and it is important to consider, not just for patients with endometriosis, but for anyone who may want to have children in the future. Egg freezing, for example, allows women to preserve their eggs now for use later, which can be reassuring given that endometriosis can sometimes impact ovarian function over time. Lisa, what are the fertility preservation options available, and how do you decide what's best for each patient?
Okay, so you already pointed to egg freezing, and that would involve undergoing a cycle of stimulating the ovaries so that they don't produce just one egg, as it would happen on a monthly basis without fertility treatment. So these ovaries are got to make really, really hard, and then these eggs are collected through the procedure I pointed out before. So if that person has a partner who she wants to be the father of the babies, these eggs can be then fertilized, resulting in embryos. And if that person is not ready for pregnancy at that stage, either eggs or embryos can be preserved for years to come.
Is there an ideal age or stage of endometriosis where fertility preservation is most effective?
Yes, I don't want people to think that egg freezing is an absolute must, because currently it's not funded by the NHS and it might not be necessary. Egg freezing, I think, at the current time ought to be recommended for those women who benefit from it most. Women who benefit from it most are those women with very advanced endometriosis at young age, especially endometriosis resulting in large ovarian cysts on both ovaries, or women who had endometriosis from an early age that keeps coming back severely. So these are women who are at risk of requiring multiple surgeries and loss of ovarian reserve. I also just want to add the caveat that endometriosis as such has an impact on the quality of eggs. And when I talk to my fertility colleagues, I often get the feedback that the result of fertility treatment in endometriosis patients often reflect, in a young woman, reflect that of an older woman. So there's a less good response to fertility treatment in a subgroup of endometriosis patients. Endometriosis is the natural aging of ovaries and eggs. Having family earlier, it is very, very beneficial. And also, breastfeeding, carrying a baby, these are natural way of suppressing endometriosis for that time. So these are, a holistic helicopter view of someone's reproductive life is very important.
We are going to move on to the holistic approaches.
Okay.
So beyond medical treatments, many patients seek holistic ways to manage symptoms. And I know you believe in a holistic woman-centered approach to gynecological conditions. So I want to talk about diet and lifestyle. We know that endometriosis is primarily thought of as a gynecological condition, but for many patients, the symptoms go far beyond pelvic pain. In fact, research has shown that up to 90% of people with endometriosis experience IBS-like symptoms, things like bloating, abdominal discomfort, and changes in bowel habits, which can make diagnosis even more complex. Lisa, what's your take? Is there a link between IBS and endometriosis?
I believe that from very early on in my training. At that time, we were often told when you see someone with pain, they either have endometriosis or they have IBS. However, when these women then had more diagnostics, I often saw that they had both. And I believe that the female organs and the bowels are in very, very close proximity. They're basically cheek to cheek. So if there are pro-inflammatory release, I'm not surprised at all that the bowels are responding to chemical information that is being given out. Sometimes we have a situation where because of adhesions, the bowels are affected, and I often hear so many of people during menstrual periods having great trouble opening their bowels because it causes so much pain. That could be linked to endometriosis involving the wall of the bowel, but it could also be linked to endometriosis nearby. And often these women respond well to surgery. However, I believe that when you look at dietary and lifestyle approaches, it is all part and parcel of living well with endometriosis and taking charge and living with a condition that can cause pain. So it's this self-management. I see that very much as part of self-empowerment. And I often find that when the endometriosis diagnosis is given in the first place, there's sort of a hot sink situation. Women feel overwhelmed. But then when they learn about things that they can do themselves or that medicine can do, people become a lot more empowered and more in control of their lives, and dietary interventions are part of that because, and that has also been backed up by studies. There is a subgroup of women who have IBS-like symptoms with endometriosis, and in the community, this is called the end of belly. So in clinic, I often see blown up tummies. Women tell me people think they're pregnant. So this is caused by gas formation in the intestines, and obviously imagining that if there's gas inside the intestines are a hollow tube of muscle. They don't want to explode. So what do? They go into sort of crampy, colicky pain that is often very sharp and short-lived, and many women would say this is part of the endo experience, and there are treatments available for that. I have read a lot around this because in many pelvic pain clinics, signposting doesn't happen. So, and because it's not necessarily written in the textbooks that IVS is a big component. I often do something called percussion, where I tap on people's tummies and then I feel painful bloating. And we know that at least there is a contribution to the pain from the intestines. There is an approach called the FODMAP, stands for fermentable foods. You want me to go a little bit into that?
That was what I was going to talk about, actually.
Okay.
I'm glad you brought that up. So I was going to talk about diet. I was looking into the research about how the gut microbiome might play a role in both the development and progression of endometriosis. And the connection between endometriosis and diet is an area that's gaining momentum in both scientific circles and the media. More people are talking about how certain diets might help manage symptoms, from anti-inflammatory to low FODMAP and gluten-free approaches. So like you said, FODMAP. That stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. These are short-chain carbs that can be difficult to digest and often trigger bloating and discomfort. The low FODMAP diet involves temporarily eliminating these foods and slowly reintroducing them to pinpoint individual triggers. While it's certainly not a cure, dietary changes, when tailored and supported by healthcare professionals, can offer meaningful symptom relief for some people. Do you ever recommend dietary changes?
I do, and you've outlined all the important ones that I mentioned. So if we touch on the FODMAP diet first, subgroup of women with endometriosis, certainly not everyone, but a subgroup who benefits from looking at the FODMAP components in their diet.
Yes.
Just as an example, there's fruit sugars called fructose, there's lactose, polyols, and others. And I believe there's great value in eliminating each food group for 1 month and recording whether that has helped with the bloating. So let's say it's August and we're starting with a FODMAP diet. And we'll do lactose first. So 1 month dairy-free. Obviously, there are now plant milks available or lactose-free dairy products that are permitted. And then after that month, the idea is to review your symptoms and see if you got better, if you actually improved, you found your trigger. If you haven't improved, you move on to the next group, which may be fructane, so fruit sugars, and avoid food high in fructose. And again, over the month, monitor symptoms. And if that has actually given relief, then again, we know we're onto a trigger. So there are downloadable tables that group all these foods together in these groups of FODMAPs. And then within 6 or 7 months, you could have worked through the whole table and found out about your food triggers. There are 2 over-the-counter medications I would highly recommend to try because they can make a big difference. And that the first one is called Simeticon, which is an anti-bloating medication. And then that has peppermint flavor, tastes slightly chalky, that can make a big difference. And then we have another one called Mibeverin, and that is for people who have this strong intestinal response just after eating food. And that Mibeverin can be taken half an hour before eating, and that it relaxes the intestinal system.
Nutrition, of course, is just one piece of the puzzle. Do you talk to your patients about stress management and exercise?
Do. Surely not everyone with endometriosis has pain every day. There are women who have many days of pain in a month and feel that a change is actually something that is meaningful for them and they want to embrace it. And then I have other clients who hand the responsibility for endometriosis treatment over to me and would rather like to have surgery. Regarding exercise, I believe that exercise is valuable in managing endometriosis, both the physical but also the mental health side effects of endometriosis. My favorite study is a small study from South America that has shown that women with endometriosis benefited from doing group yoga outdoors. And what I like about this activity is that it has 3 components to it. There's exercise, there's a peer group, and it happens in daylight in the presence of sun. The benefits here are vitamin D levels go up. So obviously not everyone likes yoga, but the exercise that I recommend is with someone else outdoors. It can be, walking as long as it's with someone else, because I think that's really nice for mental health to have company. It releases endorphins that help endometriosis pain, and daylight is also good for mental health and lifts vitamin D levels. So really important to find exercise that you like, because there's no use in forcing yourself to doing something that doesn't work for you. With regards to relaxation, I also believe this is very valuable. And the reason for that is that in a situation where there's chronic pain, the body always has to deal with something. It causes a degree of stress, and we'll often find that the sympathetic nervous system, that is the stress response nervous system part of the body, is very activated. And the counterpart, like yin and yang, the parasympathetic nervous system is the chill out part of the nervous system. So what we want is to increase the parasympathetic and suppress the sympathetic nervous system response, and this can be achieved with relaxation. There are relaxation exercises from many traditions. I did a little bit of work with Headspace in the endometriosis clinic, and we co-developed the pain module on the Headspace app. So the Headspace promotes mindfulness meditation, which can help lower that subconscious body stress response that's going on. And during working, the work with Andy Puddicombe, I understood that 3 times a week seems to be an important number. So for the gentle exercise outdoors with someone else, if you can get in 3 little bites of that in a week, and also 3 meditations or other relaxation exercises, that can really make an impact. And just be aware, you don't have to do the meditation or the exercise when you're going through a pain flare. That is probably not the time to push it to the limit. It is a bit like learning to play an instrument, both with the exercise and the meditation. It's a skill that stays with you even when you go through a flare.
Now I want you to tackle some common myths that I've heard in the public about endometriosis. So, for example, I've heard that getting pregnant will cure it, or that it's just a part of having a difficult period, and these misunderstandings can be harmful as it leads to the condition being dismissed or misunderstood. What are some of the biggest misconceptions you have heard from patients or even from the public?
I hear a lot of what you're telling me regarding what we call normalization. And there's this term medical misogyny. I think the lived experience of many of the women who come to my clinic. I hear this story of, women sharing that they have very bad periods, and that is then normalized by their family doctor or another clinician, or even within the family, as, being part of the female experience. For diagnosing endometriosis, for a doctor, for instance, for your GP, it would be really important to know that there's not only period pain, but also pain during sex. But who would want to share that if the first symptom of painful periods get dismissed? So then often women hold back the information on painful sex, which is important for the diagnosis making. And that can be very detrimental because the endometriosis possibility is not flagged up soon. Some women are given medication with best intention, are being offered hormonal contraception, but the diagnosis of endometriosis is not put on the table. So the doctor might think this is presumed endometriosis on the milder spectrum, and that contraceptive helps, but they don't give it a name. I think it's very important that when treatment is started, that we have a label and say, we're starting the pill for presumed endometriosis. Yeah? Because that also shows that there's an acknowledgement. But this myth about pregnancy curing endometriosis is not true, but there is a kernel of truth in it. During pregnancy, most cases, the endometriosis lesions lie dormant and they are suppressed. And the same is true for breastfeeding. And that is why I encourage women who want to approach endometriosis naturally to breastfeed as long as possible to suppress ovulation, because it's ovulation and the resulting hormone levels that feed the endometriosis lesions. But it's all a way of how that is being communicated. And I don't want women to think the only way to live better with endometriosis is giving birth, especially if there's fertility issues. It can be very painful if pregnancy is highlighted as a possible cure. So I don't want you to think that pregnancy cures endometriosis, but it is true that often endometriosis pain is better in pregnancy, and having babies earlier in life might overcome infertility issues that are difficult to resolve later in life.
Okay, so for our final topic, I want you to give advice for someone who's newly diagnosed or feeling overwhelmed by their symptoms.
Well, I think there's always it's sort of a mixture of feeling that comes with a diagnosis. Me having been diagnosed with conditions myself, there's often, that heart sink moment, but then there's also an element of relief. It has been given a name, and once a diagnosis is made, we can work on it. And although endometriosis has this label, it's incurable. I think with the collaboration of a good medical team, a proactive GP, and these lifestyle changes that we touched on, although endometriosis cannot be completely cured, people can live well with endometriosis. And so coming back to your, theme of fertility, on many occasions, endometriosis patients of mine, I've met them on labor ward, and some of them, I delivered their babies.
Oh, that's so nice.
And I can share hope. This is possible. And it is important to find, clinicians, physiotherapists and GPs who have a good rapport with you, who listen to you and who work with you on living well with endometriosis.
Thank you so much, Lisa. This has been incredibly insightful. That's all for today. A huge thank you to Lisa for joining me and sharing such invaluable insight. If you found this conversation helpful, please share it with someone who might benefit. Thanks for listening. Bye, everyone.